Thank you all for joining us tonight. I'm going to go ahead and introduce Dr. Reed, and then I'll go ahead and give him the floor. So Dr. Reed is a college graduate of West Georgia, where he received his BA in biology. He then went to Mercer University School of Medicine in 2000. Dr. Reed completed his internship and residency in internal medicine at UAB, along with his fellowships in pulmonary medicine, critical care medicine, and sleep medicine. Dr. Reed is board certified in internal medicine, pulmonary medicine, critical care medicine, and has 2 certificates in sleep medicine. Dr. Reed has been practicing in Carrollton in a private practice, focusing on all the above specialties since 2007. He is also a medical director with Tanner Medical Center in Carrollton's critical care unit, as well as a medical director of the sleep centers for Tanner Medical Center in Carrollton, Billerica, and East Alabama. He has been married to his wife, Tina, for 28 years. He and Tina actually met his freshman year in college while holding a position as a patient tech at Tanner Medical Center in Carrollton, and Tina was a ward clerk. The 2 of them now have 2 children together. Dr. Reed, whenever you're ready.
Okay, thank you, Hannah. I appreciate it. And we hope to get together tonight and talk a little bit about lung cancer. As a pulmonary medicine or a lung doctor, that's a subject that's very important in our world, because we do see a lot of lung cancer. We deal with that on a daily basis, so it's something we like to talk about. And just to come very clean from the beginning, just to realize that when you talk about the treatment of lung cancer or the diagnosis or just care of lung cancer patients in general, there's a lot of people involved in that team, and pulmonary is a small piece of that. But our job is primarily the job of diagnosing lung cancer. We have a very small hand in any treatment. That's other specialists who tend to do the lion's share of the treatment of lung cancer. But our jobs are primarily diagnosis of lung cancer, but also screening for lung cancer, which is very important. We'll talk more about that. And most importantly, the biggest part of our job is in trying our best to prevent lung cancer from occurring to start with. And so with that, we'll get started. This is just a really kind of a short presentation, but just about the sort of pulmonary approach to lung cancer and the things that we think are the most important there. If I can get my screen to switch, there we go. So just a few points about this to start with. Again, prevention is the most important thing we can do in my job when it comes to lung cancer. And you may say, how do you prevent that? Well, lung cancer, more so than other cancers, where we may not have a really firm grip on what might be all the causes of cancers of different sort. With lung cancer, we know that this is really primarily a cancer that we see in cigarette smokers and very long-term cigarette smokers. If we can stop the smoking, we can literally stop almost all of the lung cancers, not all of the lung cancers, but almost all of them. So since we know an absolute cause and we have a way to intervene on that, that's the number one part of our job, is in prevention. So you'll see the first bullet point on my slide here. Prevention is the most effective approach we have, rather than screening. But we can't always prevent all of the lung cancer, so we need to screen for them. And we have people who have stopped smoking many years ago that can go on to develop lung cancer. We need to have an effective way to screen for those patients. So I want to talk about that in a little more detail. First of all, smoking does cause more than 90% of lung cancers. If you add secondhand smoke in there, which can also donate to lung cancers, we definitely know it increases risk for lung cancer in non-smokers if they're around a lot of secondhand smoke. But when you include that, smoke and smoking related causes, even from chronic heating smoke, smoke of any sort, accounts for probably more than 95% of lung cancers we see. And we want to screen those people when it's appropriate for lung cancer. And only about 15% of the people who should be screened in this nation have been screened at all at this point. So we have a lot of work to do there. So as you see in this image here, lung cancer is a cancer that literally starts, it's an abnormal growth of cells that starts within the lung. It can start from several different portions of the lung, from the airways, from the nerves in the lung, from several locations in the lung, but it starts in the lung. So lung cancer, it is the leading cause of cancer death in the United States. In fact, it is it causes more deaths, cancer deaths in the United States than the next three most common cancers combined. So if you take everyone who dies of colorectal cancer, breast cancer, and prostate cancer every year, more people die from lung cancer than all three of those combined. So it's a very serious disease and one that we really want to work to avoid. There's about 234,000 new cases every year in the United States diagnosed, many of which are cured, but there are a lot of cases. Very importantly, the outcome in a lung cancer is really related to the stage at diagnosis. The stage makes so much of a difference in this outcome. So, we stage lung cancer just like we stage most cancers. Sort of a stage 1 is a very, very, very early cancer, and a stage 4 is a much more advanced cancer that usually is spread to other organ systems. So, for instance, a lung cancer that has spread to the liver or to the adrenal glands or to the brain or somewhere else would be a stage 4 cancer. So our goal is to find very early stage cancers because those tend to be more treatable and more curable. We'd much rather, if someone's going to develop a lung cancer, we want to find it right when it develops, if that's possible. And it's not always possible, but we work hard to do that. So we want to find them early. Again, smoking cessation is mentioned here. When we look at risk factors for lung cancer, there are several known risk factors. We could talk about several of them, but again, smoking and secondhand smoke really make up the lion's share of all of the cases here. Radon is a known probable pathogen. We can have that in our basements. It is in basements in this area we live in also, but again, it's not fully understood just how much risk is associated with radon, but it is felt that it could increase the risk. Diesel fumes are also known. Diesel mechanics probably have a higher rate because of this. Also, family history can play a role also, and there's several other risks that are very, very tiny risks, but again, smoking and potentially secondhand smoke tend to be really the largest risk factors there. This is just a map, just giving you an idea. We're looking here at all the new cancer development, the rates at which they develop. The dark blue is the highest rates we see in the United States. The lighter blue is next. The really pale blue is next. And then the white is the lowest. And what you'd find is this map also follows very closely where people smoke more than others as well. So now to talk about screening, which is something that's extremely important in what we do, is trying to screen people for lung cancer. So even if people have quit smoking several years ago, their risk is still elevated for lung cancer, potentially for the rest of their life somewhat, but after about 15 years, that risk tends to be not much higher than someone who never smoked. So the risk gets very low after a number of years. But there's been lots of clinical trials done on what is the best way to screen for lung cancer. It's interesting on this video here on this slide here, there is a chest x-ray here, but that chest x-ray has been shown definitively in clinical trials not to be very helpful as a way to screen for lung cancer. Chest x-rays will diagnose a cancer sooner than not doing a chest x-ray, but unfortunately it has no effect on outcomes. In other words, chest x-rays, by the time you find a change on a chest x-ray, there's typically fairly advanced disease, and we want to catch it much earlier than that when we can. So there's several very large clinical trials that have gone on in recent years that have shown that a CAT scan of the chest tends to be a way that we can find cancers earlier and save lives. And the type of CAT scan we do is called a low dose CAT scan of the chest. And that low dose means we use a much lower dose of radiation. The picture's not as perfect as a regular CT scan, but it's plenty perfect to find these small nodules, these lumps and bumps in the lungs that we're looking for. And you only get about 1/5 of the radiation you'd get from a normal CAT scan of the chest. Again, this is a low dose CAT scan, and this tends to be extremely useful. And this is something we would do dozens and dozens per week. We would order of these scans here, looking for lung cancers in appropriate patients. Those appropriate patients in the clinical trials have been shown to be patients who are at least 50 years old, up to 80 years old, generally, who have smoked at least one pack of cigarettes a day for 20 years. We call it 20 pack years. Now, it could be not just one pack a day for 20 years, but it could be the equivalent. So it could be 2 packs a day for 10 years, or it could be a half a pack a day for 40 years, as long as it comes out to 20 pack years. That's the recommendation, is that we would screen those people, and we would do this low dose CAT scan on those people every year until they've been quit smoking for 15 years. Because again, at the 15-year mark, their risk for lung cancer, again, is not much more than non-smokers. So we stop after 15 years. Now, there are pros and cons to the low-dose CAT scan that we have to talk about with patients, and that's why this needs to be linked to an educational visit with a patient, because the low-dose CAT scan in of itself mostly is a very good thing. It's all pros because it's going to help find lung cancer very early so that it can be a curable disease. The cons, there's a few drawbacks to it. So there is some radiation exposure. That radiation exposure, again, is very small, relatively speaking, but it is very real because it's a scan that you may get for 15 years, right? So there is a cumulative dose there, but that radiation is real. It radiates not just your lungs, but also breast and thyroid and other chest structures. And there's, you don't want to be radiated for no reason, but this is a pretty good reason to receive some low dose radiation. But that is something we have to think about because radiation itself is a carcinogen, we know. Sometimes, in fact, most times we find small nodules in people's lungs. So think of a nodule as just like a little tiny BB or a little tiny something smaller than a marble. But we call this a nodule in the lungs, and nodules is what we're looking for because cancers start as small nodules and then they grow and grow. About 95% of the time, those nodules are going to be something benign and of no importance. In fact, they're usually old scars from a particular fungal disease that we have right here where we live. It's very endemic. Almost all of us will have this fungal disease during our lifetime if we live long enough, and it leaves little spots in our lungs. In fact, there's about 500,000 people infected with this fungus every year in the United States, 500,000, particularly in the Mississippi River and Ohio River valleys. But that fungus leaves little spots in our lungs. When we do these screening CTs, we see those little spots, and probably at least half of these CTs we do, we're going to find some kind of nodule on there, but usually they're very small and we know they're benign, and we just check on them when we do that scan in a year again. Sometimes we find nodules that are a little bit bigger, and we have to do a scan quicker than a year, because if we have a nodule we're kind of concerned with, we don't wait a year to do their next scan. We might do it in 3 months or 6 months. Well, again, those are usually going to be benign, but that can cause some stress in people. Some people really stress about this, and it's a real burden for them, worrying about, what is this nodule? Wow, I've got to wait another 6 months to hear something else. So that's a con to this scan, is some people really get concerned about these nodules. We try to reassure them and teach them this is really not the way you have to think about it. It's very likely we're going to find nodules. It's very unlikely any of them will ever be cancer, but in the long run, this is meant to save lives. But again, there's some drawbacks to it. Sometimes we find on the CAT scan that the heart arteries, the coronary arteries, have a lot of calcium in them. And the radiologist will read that as, hey, there could be some heart blockages or heart disease based on that calcium. You might want to work that up. Well, again, that may or may not be real, but may be a significant source of stress to the patient also. So there can be some cons along with pros to getting the scan. Overall, it's a good thing. Most patients deal with it very, very well, but some people, it can cause some distress to worry about getting screened every year. So we have to have that conversation with our patients. When I say here that this low dose CAT scan once a year until you've been quit smoking for 15 years is usually covered by insurance with age restrictions. The reason I say that is because even though the recommendation is that you do it basically from age 50 to 80, and when you smoke 20 pack years we talked about, in reality, what Medicare and most commercial payers will cover, and most of them will cover, but they cover a little different age range. They cover age 55. So we generally don't start till 55 through about 77 years old. And they want it to be 30 pack years. So in other words, they smoked a pack a day for 30 years or 2 packs a day for 15 years. So in reality, generally, we tend to screen people who are starting at age 55. Once we do this, again, most of any nodules we find are very benign findings. They require no intervention. They really require no workup other than just a yearly CT scan. But sometimes we do find a much more concerning lesion. And that's why we're doing the scan, because if that lesion is going to develop, we want to know it. But we find a lesion that's definitely larger, or one that shows obvious growth from year to year. And once this gets big enough, once this gets about 10 millimeters or 1 centimeter in diameter, that's about like if you chipped off the end of your pinky, about that big. Once a nodule gets that big, we can actually do some further workup without having to sample that. We can do something called a PET scan, and a PET scan is widely used in cancer diagnosis and in surveillance and treatment. But a PET scan gives us a picture like a CAT scan, but it gives us a picture of the nodule's metabolic activity. So cancers are very rapidly growing and dividing, and the cellular machinery is running hard there. So they light up very bright on a PET scan. So it actually gives us a color, and we measure just how colorful this lesion is. The more colorful, the brighter, the redder, the hotter it is, the more likely it represents a cancer. Now, oftentimes we do this and there's absolutely no activity there. And if there's no activity there, it's highly unlikely that it would ever turn out to be a cancer. We continue to follow it, but it's very unlikely to be a cancer if it is negative on this PET scan of the chest. Some of those lesions go on. The PET scan is very, very, again, very colorful, very hot, and suggest us, hey, this is probably a small lung cancer. That leads us to do a biopsy. And those are biopsies that are done by myself or my partner, or by even more commonly by our interventional radiologists, who are wonderful at biopsying these lesions. Depends on where it's at, who does the biopsy, basically. If we diagnose lung cancer, we diagnose quite a few here every year, then we decide we have to figure out, is it right to try to do surgery and take this out? You can't take everything out. If things are advanced and there's lymph node involvement, for instance, you can't take it out. But our goal with the low dose CAT scan is we find these small lesions that are a solitary lesion. The PET scan is otherwise completely negative, and it's in a patient that has good enough lung function that we're able to take out that lobe of their lung, which is a lot easier to do these days than it was 20 years ago. And we can actually cure those patients. And we have hundreds of those patients in our practice that have had this surgery and are doing wonderful. For patients who have more advanced cancers that we can't treat surgically, we refer them to other specialists here in this in the Tanner County Cancer Network, the radiation oncologist, as well as the medical oncologist, who are the actual folks that do the bulk of the treatment for these more advanced tumors. So at Tanner, in that instance, for instance, if I diagnose somebody with a lung cancer, if it's small, which is what is usually the case, we find smaller lesions and we have them resected and taken out by the surgeon. And we're sort of done there. We follow them with CAT scans. But those that have more advanced cancers and may need chemotherapy or radiation therapy and or immunotherapy, the newest type of therapy, we refer them through the 3-day Tanner program. So that program is a program that once you have a diagnosis of cancer, once we have a biopsy and we know what we're dealing with, then Tanner, we get you in that system very quickly, and their oncology services basically within 3 business days typically will we'll finish that evaluation and come up with a treatment plan for the patient. And that really works very well. And it's just been a wonderful thing for our community. Also have patient navigators within that program, are folks that the cancer patient gets assigned a navigator, and the navigator is available to help make sure everything gets done in a timely fashion, and they're someone they can communicate easily with. When we look at our network specialists, we have 359 providers on medical staff representing 35 medical specialties. So we have almost every medical specialty possible in our centers. Also have dietitian support, spiritual support, mental health support, lots of things. These are some resources also. And one more time, I would say that from a lung standpoint, again, our major job is prevention and doing our best to help people quit smoking. We love to do smoking cessation counseling. We use smoking cessation aids in appropriate patients who are really well motivated. We work hard to get all our patients to stop smoking. We screen appropriate people who need screening, and there's a lot of those people out there. And when we do find a cancer diagnosis, we have wonderful ways of dealing with that very rapidly with best practice care here in the Tanner Network. And with that, I'll turn it back over to you, Hannah.
So, Dr. Reed, have y'all seen any effects that vaping has had any effect on causing lung cancer?
So I think the jury is probably still out on that. I'd be personally pretty surprised if it doesn't show conclusively to increase risk of lung cancer, because most things that we inhale in any particular concentration, any high concentration, really seems to turn out to donate to lung cancers, anything other than clean, dry air. So I suspect it certainly can cause other forms of lung injury, which we've certainly seen. And I think it will prove that vaping may not be any safer than smoking cigarettes in the long run, personally.
Interesting. Are there risks with biopsies?
There's definitely risk with biopsies because by definition with a biopsy, we're actually taking a piece of tissue. And it depends on what type of biopsy we're doing. Some biopsies are more risky than others. And that depends on where the tumor is. Of course, these tumors are in the chest where there's obviously a lot of important stuff, great vessels, lungs, heart, lots of things we have to be very careful with because we are working within that system trying to get an actual piece of tissue, which we do really two major ways we would do that. And in any center, this would be the two major ways. For people who have lung cancers or masses within their airways, myself or my partner, Dr. Ronig, we bring those patients in the hospital. We put them to sleep. We actually go through their nose or mouth with a flexible scope with a camera on it. And we actually go in the airway where we can see this mass, and we take alligator forceps, really tiny alligator forceps, and we literally pull pieces of tissue off of that. Now we do lab testing and go to other measures to make sure people don't bleed, but bleeding can be a real problem there. But life-threatening bleeding with the biopsies we do is very, very uncommon, probably less than 1 in 1,000 or 1 in 2,000 procedures. Many people have their lesions on the outside of the lungs, like just under the rib cage. Well, those are places we can't get to. We can get to the middle of the chest, which I was talking about when we did bronchoscopy down the nose or the mouth. Things on the outside, the radiologists do needle biopsies, and they do that under CAT scan, using a CAT scan to guide them. And they're extremely good at that. They do a large amount of those, but there's certainly risk to collapse the lung. So you picture the lung is not really like a balloon. It doesn't pop, but it is an air-filled organ. And when you invade it with a needle, that lung tends to collapse just a small bit. Usually there's no intervention needed for that. Over a couple, 3 days, it will reinflate on its own. But every now and then that lung will totally collapse, and we have to put a little small tube in there for a few days as an outpatient, usually not even admitted to the hospital, but as an outpatient, we help that reinflate. Bleeding obviously can also be a risk with the needle biopsy, and there's just no way around that. But those risks are really very small overall in the big picture of things, because the alternative is you don't biopsy it. We don't have a lot of choice in a lot of these. It's got to be biopsy because we can't get treatment without it in most situations.
Sure, thank you for that. Should you be concerned if you've had a cough for longer than a month and it's still not getting any better?
We consider, technically, chronic cough is defined as a cough that lasts more like about 8 weeks or so. So it's extremely common to have persistent coughs. And in the lion's share of people, it's just absolutely benign. It's caused by either sinus drainage or lung inflammation, or simple reflux can do it. By far and away, the most common cause of chronic cough is sinus, and posterior nasal drip is extremely common, and it definitely causes the lion's share of all the chronic cough out there, even in smokers. But having said that, your threshold for getting looked at for a chronic cough should be lower depending on your risk factors. If you smoked for a very long time, if I couldn't quit coughing in a month, and it was definitely a new cough, I would probably see a doctor to be evaluated for that. Definitely if you cough up blood. It may sound silly, but I've had many patients over the years who thought it was normal to cough up some blood here and there, but I'll tell you today, that's not normal. So anybody who has a bloody cough, or very foul, discolored coughs that go on and on, those things should be checked out for sure. But just a nagging dry cough in someone who's a non-smoker is very unlikely to represent anything serious. It's much more likely in those people to be related to postnasal drip or reflux. Lots of people are treated for high blood pressure with a very common pill is lisinopril. Lisinopril has been on the $4 plan at Walmart as long as I can remember it. I'm on lisinopril personally. It's used in just tons of people, but this class of drugs, about 20% or so of people, it's thought will have a dry hacking cough that will not go away until you get off of it. And we can switch that to other drug classes that are just as cheap and work just as well if you develop a cough of that. But that's another very common cause of chronic cough. But in short, if your risk factors for lung cancer are much higher because you smoked a long time or you worked in incredibly dusty, dirty environments and diesel fumes, etc., I'd get seen about quicker. If you're very low risk, I'd probably let it go a little longer, 2 or 3 months, but I would certainly have it checked out if it didn't go away.
Sure. And the last question is, do you have to be referred to a pulmonologist or can you just make an appointment?
Yeah, essentially, I don't know of any insurer that's commonly accepted here that requires. We don't really have any of those sort of gatekeeper models where you have to have a referral. There may be some of the Medicaid CMO programs, Peach State, Care Source, WellCare, etc., that may require a referral, but almost no payer. So most of your commercial insurance is not going to really require a referral. Medicare of any sort that I know of doesn't require a referral either. You can just call, make an appointment.
Okay, well, Dr. Reed, that was all the questions that came through. If anybody else doesn't have any questions, then we'll let you go. But thank you so much for joining us tonight and presenting.
Thank y'all. My pleasure.
And yeah, and thank you everyone for joining us as well. There's other classes and events coming up on our website. You just go to tanner.org/classes and events. So thank you all. Have a great evening.
Thank y'all.